You mentioned some studies there that have really supported your thesis that Ozempic is more than just a weight loss drug and that it has these other sort of regenerative properties and these healing properties. What are some of the studies? You've got some things in front of you there that you brought with you. What are some of these studies that highlight this in your view?
Well, so there's one study in particular that I don't have the title of it written down, where they looked at all of the data on all of the GLP-1 agonists that are out there, the different versions that I mentioned. And they went back through all of the studies and they looked at it system by system by system. And I gave your team a link to that. And what they found is, I mean, going from tip to toe, neuroregeneration and anti-inflammation in the brain. They showed improvements in cardiovascular tissue. We just had a study come out at the end of 2023 called the SELECT trial. It was a big one. Yes, it was sponsored by Novo Nordisk, who's the manufacturer of semaglutide, I should say, of Ozempic. And so people say, oh, don't believe those studies. It was a well-done study. It looked at individuals in their 40s who were overweight but did not have type 2 diabetes, and it showed a 20% reduction in severe cardiovascular events. So stroke and heart attack and others. And so then people argued once that came out and said, oh, well, that foof, Novo Nordisk did it. And that would happen if people lost weight anyway, right? You'd have improvements in cardiovascular disease. Well, they just looked at the data again and realized that those benefits were independent of weight loss. Whether people lost weight or not, they still had significant improvement in cardiovascular outcomes, which there's just nothing, we don't have anything out there that does that. I found data showing regeneration of pancreatic tissue, beta cells in type 1 diabetics, if given early enough. So if a person is type 1 diabetes is an autoimmune condition where the pancreas becomes destroyed by the immune system. It's different than type 2. We don't have anything to help those people. It used to be called juvenile diabetes, and then type 2 was adult onset, but now kids, many children are dealing with type 2, so it's a big mishmash. But they're two different processes. They shouldn't even have the same name. Anyway, done early, reversal of that pancreatic damage to the point where people didn't need to go on insulin and were able to have pancreatic healing. We don't have anything that does that except stem cells. At the end of 2023, they had to stop the FLOW trial because this was a chronic kidney disease trial. They had to stop it because the control group, they needed to be able to ethically give the control group the substance because it was so effective. It was so effective at reversing chronic kidney disease and kidney failure that they needed to be able to offer it to the control group ethically and not let them continue on their journey of kidney damage. So we've got this mishmash of studies, and then they've done little studies here and there looking at muscle, for instance. It's regenerative to muscle. It's regenerative to bone. It's regenerative to our joints. Some of this is in mice. Some of it's in humans. It's regenerative to the testes and to sperm production and motility.
When you say regenerative to, say, muscle, when people talk about Ozempic, one of the big concerns is that you lose a lot of muscle.
Right. It's not true. I mean, it is true. Let me rephrase that. Any dietary intervention or bariatric surgery that induces a severe caloric restriction will lead to about 20 to 35% muscle mass, or I should say lean mass loss. So this is a little bit of a nuanced conversation. If you basically put somebody into a self-starvation mode, they will lose 20 to 35% of their lean mass. Lean mass is all the soft tissue in your body. So that could be your tendons and your ligaments and your brain, and they clump it all into one, and they're looking at that and saying it's all muscle. Muscle is a percentage of that. Muscle isn't all of your lean mass, right? And so that kind of makes the studies look bad there, I think. The other thing that they don't consider in that is pathologic muscle due to metabolic dysfunction will be marbled with fat.
What does that mean, sorry?
Well, it's like foie gras. When you induce metabolic dysfunction in an animal, which is what they do in feedlots for cows often, and they do it to geese to get their liver fatty, you will end up with this fatty infiltrate in the muscle. So the muscle goes from being this lovely, striated, linear, beautiful pattern to marbled with fat. Mm-hmm. And that fatty infiltrate becomes very pathologic to the muscle, and it puts the muscle itself into an insulin-resistant state. So once the marbling occurs in the muscle, it's sort of a chicken and egg downhill situation for the muscle. And I do believe very strongly, and I've been preaching this for decades, that once that process starts, and it most often starts in the thighs, you've probably seen the pictures of the cross-section of like, this is an 80-year-old triathlete and his muscle looks really beautiful and linear. And then here's, the average 80-year-old, and it's really marbled, and the bone loss is significant, and the fatty layer on the outside is thicker. But what's most important in that photo is the marbling of the muscle. We don't want marbled muscle. That's the beginning of the end. You also end up with fatty liver, and you end up with fatty pancreas when you're in this metabolic dysfunction state, this downhill journey that culminates in type 2 diabetes. And so one of the first things that happens when metabolic health improves, whether this is through dietary interventions, lifestyle, strength training, you name it, is that fatty infiltrate starts to dissolve. These GLP-1 agonists induce that process of the fat dissolving. And so I think that's part of the lean mass loss that they're measuring. They're just measuring it as lean mass loss, but we're also decreasing muscle size because we're having the fatty infiltrate start to burn itself up. GLP-1s have also been shown to perfuse the muscle with angiogenesis, so we get a vascular supply so that more amino acids are available to the muscle. So when they looked at aging muscle in a human and they gave them GLP-1 agonists, their muscle became healthier and less pathologic because it started to actually get better blood supply and be infused with the amino acids they were eating in the form of protein. And then there's pathways that are impacted as well that are inducing muscle protein synthesis. So GLP-1s actually induce muscle protein synthesis. They don't cause muscle wasting. It's the caloric restriction that's causing the wasting. And they're measuring it somewhat aberrantly. Does that make sense? That's the story I'm trying to weave here.
Yeah. So, but how can I avoid the caloric restriction if I'm taking the GLP-1 agonist, like semaglutide or Ozempic?
You don't dose it too high, so you don't crush the appetite. So the whole goal is to keep people at a dose where they still have an appetite. You don't have to crush their appetite with it. The way it's being dosed traditionally is they're ramping it up really fast and they're just devastating people's appetite with it. And so people go from hungry and starving to I don't want to eat anything, and so they don't. And then they often will eat less healthy version. They'll eat less volume of a poor diet. So they will continue to eat junk food, only less of it. They will continue to eat the crappy foods they're used to eating, only less of it. And I've heard Johan Hari on your show talk about this, and a beautiful book that he wrote, his Magic Pill book, he talks about that. He found himself about 5 or 6 months in, and he was still just eating the same crap. He was just eating less of it. And what needs to happen when anybody's on this at any dose is they need to be protecting their muscle with all their might. They need to be strength training, and they need to be prioritizing their protein macros. Like those are the two non-negotiables. I don't think doctors are always talking about that, and I don't think patients are compliant with that.
If I start microdosing, though, won't I see less of the reward? I see less of the cost, but will I not also get less of the reward, the positive upsides that you've described?
Not if you're doing all the other lifestyle things. So like I said, it opens this window of opportunity where people feel much more in control because there's impacts on the brain that allow people to be much more in control of their choices and of their thought processes and even of their obsessions. It's very interesting how it works. And so people are able to make better choices. And I think given that window of opportunity and introducing these lifestyle interventions, they're going to be much more open to it. So we get them exercising, we get them eating better, we get them doing all the things. We get them optimizing their sleep, we get them going on walks and meditating and mitigating their stress. All of those things are going to improve their metabolic health. So it's a two-pronged approach, and we don't have to crank the dose. We can do this slow and low, and some people may need more and some people may need less, but the point is the way it's being done traditionally, where it's like you get your script and you walk out of your office and you don't get any counseling, you don't get any support, this is where people are falling into, I believe, the terrible pits of despair. So this is where we're seeing the problems, and it can be done differently where we're doing a holistic, comprehensive approach with a patient.
I was reading a 2024 study by Lindsay Wang that found diabetic patients taking Ozempic were 50% less likely to develop bowel cancer compared to those on insulin. What does this say and highlight about Ozempic's role in staving off cancer?
Well, that's an interesting study because insulin is pro-grow. So insulin is also a signaling peptide hormone, very much like GLP-1, and it is pro-grow when you give it to someone. So someone being on insulin, I believe, will inherently potentially make them more vulnerable to cancer. I don't want to say certainly because I don't want to scare everybody because there's a lot of people out there on insulin, but it is a pro-grow hormone. Now, it's pro-grow in that we get surges of it after we work out, which is awesome. We want that, right? We want that anabolic response. But in your average person who's not working out and who's not really using their insulin the way they need to, they're already swimming in it due to insulin resistance, and now they're taking insulin because their pancreas is pooped out. That's a mess. That's a soup of things we don't necessarily want happening growing in the body. And so that study looked at insulin versus GLP-1s. It's not entirely fair because it's not a true control group.
Mhm.
But there are other data sets coming out that haven't been published yet showing really good, really hopeful and positive impacts on potentially reducing cancer risk. And they're correlative, not causative. So we can't put our finger on it and say these reduce cancer. But they looked at over 1 million people that were type 2 diabetics that were on semaglutide, and they found a significant reduction in different types of cancer that are obesity related in comparison to the folks who were not taking GLP-1s. And those were the cancers you don't want, the ovarian, the pancreatic, the colon, the types of cancers that are, you don't come back from readily. And so that's very exciting. It's not getting a lot of play, and it's really, really new information. So I'm excited just to watch it. But it makes sense to me because these sit on your immune cells as well. There's GLP-1 receptors throughout our entire body. That's why we're getting the impacts throughout the entire body. And I think that the impact that it's having on the overall immunologic milieu of an individual is potentially very anti-cancer.
I mean, that study that you cited there, I know nothing about Ozempic and GLP-1s really. But even in my sort of, chimp brain, I go, yeah, because if they lose weight, they're
Right.
less likely to get cancer.
Right. No, that's totally fair. And I think it's both because the way that these are working mechanistically in the body, and many of the studies that I've looked at are showing results independent of weight loss.
Even if they don't lose weight, then their cancer risk reduces.
Well, the healing and regenerative and anti-inflammatory impacts are there regardless of weight loss or not. And then you add in weight loss and you add in insulin sensitivity, you add in this healing of the metabolic dysfunction, and you're going to significantly reduce risk for everything as well.
I mean, that's a really good point, actually, because has anyone done a study where they give someone Ozempic, and even if they don't lose weight, inflammation goes down?
Well, that's what the SELECT study, the trial showed, that cardiovascular trial I just shared with you. They just relooked at that information and realized that even independent of weight, because that was the big argument everyone had is, well, of course the cardiovascular benefits will stay or will improve because they're losing weight. But they found that even in those who didn't lose weight, they still had really good cardiovascular outcomes. So yes, that's what we're starting to see. And so I think they need to start looking at these things more readily. But they weren't, right? They were just looking at here's morbidly obese people and here's type 2 diabetics, and we're going to crank up the doses and we're going to see what we see. But we're starting to get longitudinal data now. So that cancer one, for instance, was looking at patient records going way back. And so they had over 1 million people in there again, it's correlative, it's not causative, but it's showing trends. It's starting to show positive trends. And so I think that's what we have to look at, and we have to start to flesh that out.
What about mental health, things like depression, and sort of anxiety and these kinds of things?
You maybe have heard that these are inducing suicidal ideation and people are, getting severely depressed on them. And the EU opened a whole research into it, and people are very concerned about this. And yet we've got studies showing really positive impacts on depression and anxiety. And the thing I will say about that is I'm not saying that people on Ozempic are not having suicidal ideation, but that is a little more nuanced of a conversation because, number one, when you lose a significant amount of weight very quickly, all kinds of things can go wrong. You can end up with pancreatitis. You can end up with gallstones. You can end up with severe depression. Your fat stores your hormones. And so you lose your hormones very quickly. I've had patients who got tummy tucks and came in a few months later and were losing their minds because they literally just had all of their hormonal depots sucked out of their stomach. And so there's concern there that this rapid weight loss, which again, I am not a fan of. I am not a fan of doing it that way. But if you drop somebody's weight significantly, you may end up with a very depressed mood state. We've also got a bit further to go with that in that many people are using food as their dopamine source and as their crutch or as their coping mechanism. And I'm not judging. I just understand that to be true. We all have our vice. And if you take that away from someone because they suddenly don't want to eat, because we've crushed their appetite with too high a dose, then I think that we could end up with a very depressed person in front of us. However, done correctly, and what I'm seeing clinically is people are having really profound benefits in their anxiety, in their depression, in their moods, in their cognition. I'm seeing neurodivergent folks taking it who are becoming much more functional in their everyday, day-to-day. I'm seeing people who are more of a hermit, who don't want to go out in the world, suddenly venturing out, being more social. So there is an impact on the brain, and I think it's the anti-inflammatory mechanism. I think it's the dopaminergic system, the dopamine pathways being impacted. And again, if we're not cranking the dose up, I think that we can use these effectively to bolster mood, to improve cognition, to improve brain clarity. And all of that leads, an inflamed brain is a depressed brain. At the end of the day, we have to get that point really clear. Depression is a brain inflammation issue.
You've mentioned sort of sexual health a few times and fertility in passing when we're talking about Ozempic. Women's sexual health, male fertility, what is the impact, in your view, of an Ozempic intervention on these kinds of things?
Well, the fertility conversation is really daunting, and it's kind of a long one, but we are a few generations into a major fertility crisis. And they say, what is it, by 2100? 2100. By 2100, 97% of countries in the world will not be reproducing at a rate to repopulate themselves. We are looking at a population crisis. By the mid 2040s, they say sperm rates are going to be at 0. And again, that's multifactorial, but my firm belief at the root of this is metabolic dysfunction. I firmly believe that metabolic dysfunction is probably the biggest driver. If I could press a button and fix it, I would put my finger on the metabolic dysfunction button. And GLP-1s heal metabolic dysfunction. And so we're seeing reversal in PCOS, which is probably one of the number one drivers of infertility in young women, period, which is really at the end of the day just metabolic dysfunction. It's just presenting in women with high androgens. The clinical picture of PCOS doesn't always involve cysts on the ovaries. It's just I don't even know why it's called that anymore. It's a clinical picture where they have metabolic dysfunction, they have high testosterone, they have low progesterone, their estrogen gets converted readily into testosterone. They end up with hair growth, they end up infertile. It's a disaster. Many, many young women, many women in your age cohort have this condition. Many couples in your age cohort are not able to get pregnant without IVF at this point. People are not getting pregnant. I don't know. How old are you?
31.
Yes. People in their 30s are not getting pregnant. And when I ask my friends in their 30s all over the world, I say, how's the pregnancy going with, how's it going with your friends? And they're like, everybody's on IVF. I don't know what you're hearing, but that's crazy to me that 30-year-olds are having to do IVF. Healthy looking 30-year-olds are having to do IVF. So we've got sperm issues and we've got egg issues. It's both. It's not just the female's fault. It's not just the male's issue. We've got sperm health. We've got sperm volume. We've got sperm motility issues. We've got metabolic dysfunction in both groups. And what happens when we do have a successful pregnancy is that offspring is being epigenetically flagged. If the mother is obese and dealing with metabolic dysfunction, and even if the father is, that fetus ends up bathed in insulin in utero, and they come out epigenetically marked for much more severe risk of metabolic dysfunction and obesity in their own lives. And that cycle just goes into perpetuity. That's where we're at. We're several generations into this as a species. And so I'm worried. I'm legitimately, I joke that humans are going extinct. It's not funny. And I think it's really happening. And I do believe it will happen in the next few generations if we don't right this ship. And at the root of it is this overarching metabolic dysfunction. 2018 data out of the US that was published in 2021 showed that only 6.8% of US adults are metabolically healthy. 6.8. So that's 93, 94% of US adults are cardiometabolically busted.
If you love the Diary of a CEO brand and you watch this channel, please do me a huge favor. become part of the 15% of the viewers on this channel that have hit the subscribe button. It helps us tremendously, and the bigger the channel gets, the bigger the guests.